Hey everyone, and welcome to RUBIN'S Mind Lab, where we break down the latest research into what it really means. Have you ever thought about how we talk about mental health conditions? This new paper takes a really close look at borderline personality disorder, or BPD, and asks some big questions about how we treat it, how we talk about it, and even if the way we define it might be part of the problem. So, a study by Swan and their colleagues looked at the difficulty of managing BPD when different doctors and teams are involved. They talked about things like teams fighting with each other, care being all over the place, and patients being hurt by the very treatment they receive. This sounds like a big deal, right? But our author Laurence Cobbaert looked at this paper and said, "Hold on a minute, I think there is more to the story." Cobbaert argues that Swan's paper, while pointing out some real problems, doesn't tell the whole story. Why? Well, first, Cobbaert says they didn't look at all the available evidence, especially when it comes to treatments that might actually cause harm. This is where it gets really interesting. Cobbaert brings up research showing that some treatments people commonly get for BPD, like dialectical behavior therapy or DBT, can actually have negative effects. Imagine going to therapy to feel better, but instead, you end up feeling less sure of yourself, more ashamed, or even like your sense of who you are is fading away. Some people who have gone through DBT have shared that their therapy felt like they were being silenced, or that it made them doubt themselves. They even described feeling like the therapy relationships were repeating hurtful experiences they'd had before, kind of like being re-traumatized. This is a serious concern, because it means not all treatments are helping everyone, and some might even be making things worse. Swan's paper acknowledged that care can be harmful, but Cobbaert points out it didn't really say that the main treatments themselves could be the source of harm. Cobbaert feels that framing the issue as just treating BPD is hard misses a key point. It's not just about whether BPD can be treated, but how different treatments affect people, and that some of these effects can be harmful. Next, Cobbaert dives into the diagnosis itself. Swan's paper calls BPD a contentious diagnosis, but they mostly focus on the problems in managing it. Cobbaert believes Swan doesn't dig deep enough into whether the diagnosis itself might be part of the problem. Think about it this way. If the label we use for a condition is flawed, then everything we do based on that label might also be flawed. Cobbaert points to research suggesting that the BPD diagnosis might be influenced by social biases, like ideas about gender and sexuality. What does that mean in simple terms? It means that the criteria for BPD might not be a pure objective description of a mental health issue. Instead, they could be shaped by what society at the time considers normal or abnormal. Some studies even show that BPD diagnoses are given more often to LGBTQI people. And it is not clear if this is because they have more of a certain kind of mental distress, or if there is bias in how the diagnosis is applied. Cobbaert is saying that if the diagnosis itself is flawed or carries biases, then focusing only on how to manage it clinically is like rearranging deck chairs on the Titanic. We need to question the foundation itself. This is a really important point. Cobbaert notes that Swan's paper relies only on what doctors and researchers think, but where are the voices of the people who have actually been diagnosed with BPD? Cobbaert calls this a significant epistemic limitation, which basically means a big gap in knowledge. Epistemic injustice, a term Cobbaert uses, means that people are not believed or are not trusted as experts on their own experiences. When we only listen to clinicians, we might miss how people truly feel and what impact their experiences have on them. Cobbaert uses the example of splitting, which Swan's paper describes as a patient's way of disrupting teams. But Cobbaert suggests that maybe what looks like splitting is actually a person's understandable reaction to receiving inconsistent, invalidating, or even harmful care. Imagine being told by different professionals that you are splitting when you are just trying to make sense of confusing or hurtful interactions. This can make people feel like their experiences are not valid, and it reinforces the idea that the problem is with the patient, not the system or the care they receive. Cobbaert really emphasizes that the harm from BPD might not just be from people being mean to those who are diagnosed. Cobbaert argues that the diagnosis itself can actively cause harm. They use a metaphor called spaghettification to describe how the diagnosis can create confusing and unstable meanings for a person, making it hard for them to understand themselves. This internal struggle can be more damaging than any external stigma. Cobbaert highlights that people diagnosed with BPD sometimes avoid seeking help because they've had bad experiences, and the label itself can erode their trust and sense of control. This leads to a major ethical question. If the diagnosis of BPD, and not just how it is treated, consistently leads to harm, is it even ethical to keep using it in the first place? Cobbaert points out that these problems aren't new. Research from almost 30 years ago talks about very similar issues like stigma and feeling dismissed. This suggests these aren't just random mistakes, but deeply rooted problems. Cobbaert brings in a core medical principle. First, do no harm. They argue that if a diagnosis consistently leads to harm, we need to seriously question whether we should continue using it. It is not just about making treatments better, it is about asking if the framework itself is good and fair. Given all the evidence of harm, both from treatments and from the diagnosis itself, we need to think much more deeply than just tweaking the existing system. So, to wrap it all up, Swan's paper points out some real challenges in how we approach BPD, but Cobbaert argues that to truly improve things, we need to go further. We need to look at the evidence of harm from treatments, question the diagnosis itself, and most importantly, listen to the voices of people with lived experience. Without these things, Cobbaert believes our efforts to help people diagnosed with BPD might only scratch the surface, addressing the symptoms rather than the root causes of the problems. It is a call for a more honest and inclusive way of understanding and addressing mental health challenges. What do you think about this? Does the idea that a diagnosis itself can be harmful make sense to you? I think Cobbaert raises some incredibly important points about listening to lived experience and truly examining the tools we use in mental health care. It really makes you think about how we label and understand distress. Future research could really dig into how different cultural backgrounds and identities are impacted by diagnostic categories like BPD and explore alternative ways of understanding and supporting people that don't rely on potentially harmful labels. If you found this breakdown helpful, please give this video a thumbs up, leave a comment with your thoughts below. And don't forget to subscribe to RUBIN'S Mind Lab for more deep dives into psychology and science. Thanks for watching, and I'll see you in the next one.